Nationwide Children's Hospital. Dr. Streby is a member of the COG Relapse Refractory Neuroblastoma Task Force and is the site primary investigator for several NANT and NMTRC clinical trials. Her talk today is going to be on oncolytic virotherapy and its place with neuroblastoma treatment. Dr. Keri Streby.
Thanks, Pat. Thanks for inviting me today, and nice to see you all. I apologize I couldn't be here with you yesterday, but I had a patient that held me up in getting here, but totally worth it to be there for the patient yesterday and for you all today. So actually, this was a great segue. Meg did an awesome job leading me into what is mostly going to be talks about early phase studies in kids with using oncolytic viruses. Just a quick disclosure slide. I'm a consultant for Illumina Radiopharmaceuticals and Y-mAbs Therapeutics. So our main goals for today are to talk about oncolytic virotherapy. What on earth is that? It's a big mouthful. And then talk about oncolytic viruses and neuroblastoma, specifically the herpes simplex virus. Then we'll talk about some clinical trials that have been done in kids using the oncolytic herpes simplex virus, and then the future directions for oncolytic virotherapy. So we've talked just briefly about how there are immunotherapy successes in pediatrics with dinutuximab, naxitamab, chemoimmunotherapy, blinatumomab, CAR T cells, lots of things. And the immunotherapies work by activating the immune system to create antibodies to the cancer cells by CAR T cells or NK cells, by IL-2, GM-CSF, vaccines. Oncolytic virotherapy harnesses that immune system response, but it also directly kills the cancer cells by just the nature of it being a virus. And it also can deliver genes to the cancer cells so that we can make other treatments work better. So this is just a nice picture from an article in Biomedicines from last year that shows the way that oncolytic viruses work. It directly comes in and kills the tumor cells. It causes increased presentation on the surface of the cells of things that the immune system can then come and attack. It causes expression of checkpoint targets. So we may have heard about checkpoint inhibitors. So it makes kid cancers in general don't respond well to checkpoint inhibitors. But with an oncolytic virotherapy, it makes checkpoint inhibitors a potential therapy. And then it recruits and activates the immune cells. So let's go back to biology 101. What is a virus? A virus is a little teeny tiny particle that cannot live on its own. And no, I am not talking about COVID today, don't worry. It's about a millionth of an inch. So viruses are teeny, teeny tiny. And they lack the machines that are needed to live and to make copies of itself. So they require something else to keep it alive. So what does a virus do in a normal healthy cell? It attaches itself and it gets into the cell. Then it releases its genetic instructions into the cell. Then the host cell makes a bunch of new viruses. Like I said, it can't do that on its own, so it relies on the normal cells to make copies of itself. And then it breaks out of that host cell and goes into other cells, and that's when we get a cold or get sick. How do the normal cells respond? Next slide. So the host cell releases inflammatory markers such as tumor necrosis factor alpha, interleukin 6, interferon gamma, interferon alpha, and that tells the immune system, hello, I need some help. And the immune system comes in, brings your T lymphocytes, your neutrophils, your macrophages, and it says, this isn't supposed to be here, let me eat this and take it away. An oncolytic virus, when it sees a normal, healthy cell, comes in, it releases its genetic instructions, but the normal, intact host cell defenses in a normal, healthy cell turn off those virus instructions, and then the host cell kills that virus. So an oncolytic virus going into a normal, healthy cell does nothing. Now we've got nice little purple cancer cells. So when an oncolytic virus goes into a cancer cell, it releases its genetic instructions. The cancer cell has bad defenses in compared to a normal healthy cells. And so then the cancer cell, it makes a ton of the viruses, and the virus then breaks out of the cancer cell and kills that cell. And this is what we call the early lytic phase, because the virus makes a bunch of copies of itself and breaks the cancer cells. And that cell dies. Then it recruits your immune system in the late immune phase to come in and say, hey, see all these things? They're not supposed to be here. And it's things that are on the tumor cells, not just the virus itself. So it kind of can train the immune system to recognize that, this tumor is actually not supposed to be here either. So it can train the immune system to then go in and kill the cancer too. So again, the normal cell virus defenses are defective in cancer cells. The tumor cells make great virus factories, and you can genetically engineer a virus so that it can target the cancer cells and deliver other genes to make other treatments work better. So these are just some articles that were published in the 2014-2018 where we used viruses and actually were able to cure some adult cancers. We used a measles virus and were able to cure multiple myeloma in a patient. We used a polio virus to cure a brain tumor, which sounds really backwards because polio virus attacks nerve cells. And then there was another type of virus that was used in a young girl, a young adult at the age of 20, who is now a nursing student, and the tumor never ever came back. Now these are very small patient samples. Obviously these viruses haven't worked for all patients yet, or we would be giving everybody oncolytic virotherapy, but there are small stories of success coming out. TVEC was the first oncolytic herpes virus that went into clinical trial. It was a big phase 2 study in adults with melanoma, and they looked at the response rates of giving TVEC directly injected into melanoma, which is a skin cancer, versus GM-CSF. Actually, GM-CSF worked pretty well for relapsed melanoma, but when they gave both the TVEC virus and the GM-CSF directly into those melanoma cancers, they saw a 26% response rate versus a 6% response rate, and a durable response rate of 16% versus 2%. Now those numbers are all very small and dismal, but the difference size was huge. So in 2015, the FDA actually approved TVEC as the very first oncolytic virotherapy to be FDA approved. So why are we talking about this for kids? It's a targeted therapy, so it goes in, it kills the cancer cells, it doesn't hurt any of the other cells, and it has very minimal late toxicities, or would have a low expectation to have late toxicities. Patients and families are willing to undergo additional biopsies or blood collections to help future patients, and that's something that's important to the field of oncolytic virotherapy to make sure that it's working. And we're in this new exciting era of whole exome sequencing where we could learn a lot more about what's going on in the patient's tumors and with the virus. And there are very few novel approaches currently available, as you guys have heard, but we're getting there. We're still working together to find more. So we looked at what pediatric cancer types would oncolytic viruses work well for through something called the PPTP, or the Pediatric Preclinical Testing Program. And we found that it worked really, really well, both in the tumor cells just in the dishes and in the mouse when we implant the tumors in the mice. Oncolytic viruses worked really well for neuroblastomas, a tumor called MPNST, rhabdomyosarcomas, osteosarcomas, hepatoblastomas, rhabdoid tumors, Ewing sarcomas, so a bunch of tumors. So why oncolytic viruses and neuroblastoma? I don't need to tell you guys, there's a huge need for new treatments, and we want to minimize the toxicities that our kids see, especially because of all the treatments that they already go through. So the oncolytic viruses in pediatric clinical trials that have been tested to date include herpes simplex virus, Seneca Valley virus, Rio virus, and vaccinia virus. And I put for you guys in parentheses the number of kids that had neuroblastoma that were treated on all of those trials. I will throw in the caveat that on these studies, the neuroblastoma patients had no significant adverse effects, but unfortunately we didn't see a lot of responses yet either. So in the lab, actually, just a fun little fact, it didn't come up. There was a girl named Dr. Alice Moore who back in the 1950s studied Russian Far East encephalitis virus. So she just gave this virus to mice with neuroblastoma, totally went away. but the mice all died from the virus infection, so that was no good. So now we've learned through technology how we can genetically change the viruses so that they only go in and kill the tumor cells and not kill all the mice. We've seen tumor growth reduction in cures in mice models in current labs. The virus given into tumors under the skin in mice, like neuroblastoma tumors, has led to regression of an intracranial neuroblastoma. So there was a tumor both in the skin and in the brain, and we injected just the tumor in the skin, and the tumor in the brain went away. There we can see increased cytotoxic T cell activity against neuroblastoma cells for over a year. So lots of exciting preclinical data. And we also we know that cytotoxic T cell activity is still there because when we try to put new tumor cells back into those mice, the tumors don't grow. So that's what we call a tumor re-challenge. And if the tumors don't grow, that means your immune system is doing a good job of saying, this is cancer, we're gonna go kill this and not let it come back. So this is some of our data from my days in the lab as a fellow. This is looking at the neuroblastoma cell line CHP134 and showing you that the oncolytic herpes virus HSV1716 increases the amount of virus over time. That's what this little blue graph is showing you. And then the red graph shows that as you increase your dose of virus, you have more cells that die. Then this is looking at, we've got our little mouse. Where's my little pointer? We've got our mouse. We give him a neuroblastoma tumor under his skin. We give him 3 doses of virus directly into that tumor. If we give just saline into the tumor, all of these tumors grow. When we give the virus, none of the tumors grow, and in fact, they all go away. And then looking at survival curve, again, the mice that just got saline, all of them died around 20 days, and the mice that got HSV1716 were all still alive. Again, mouse does not equal patient, but still, this is what leads us to getting to the drug development. This is showing that when we inject the virus into the tail of the mouse, so neuroblastoma, for example, it's often in multiple places, right? So we can't just inject it into the tumor all the time. So we looked at if we inject it into the tail, does it go to the tumor? And in fact, as you can see, when we put it directly into the tail vein, we look at it by imaging 3 days later, and you can see, oh, look, it's just where the tumor is. And even 3 weeks later, you still see that the virus is in and active in that tumor, and it's much smaller. So what is herpes simplex virus? It's a double-stranded DNA virus. We like to use that one because it's got a big genome, meaning we've got a lot of stuff we can mess with and a lot of room to put stuff in. We could add in IL-2 or IL-12 to make it more immunogenic. It has a well-defined clinical spectrum. We know what HSV disease looks like. This is the herpes simplex virus that causes cold sores and encephalitis, not the herpes simplex virus that is associated with STDs. It infects a broad range of cell types. It causes those cells to break, and it's also attracted to neural cells, which is why we liked it to look at it for neuroblastoma. So an oncolytic virus acts in rapidly dividing cells, not in the normal mature resting cells, and we have shown in the lab that it's safe in a broad range of normal cell types. And this is what the virus looks like. So a normal herpes simplex virus looks like this. And then the HSV1716, or Seprevir as it was called, is deleted for ICP34.5, and that's the gene that makes it so that it's not as active in normal cells, but it still works in cancer cells. So there have been safety and efficacy models in preclinical studies of pediatric cancers. It's been shown to be safe and effective in over 90, and even more now, adult patients. So our questions were, is this safe to give to kids with cancer? Can we give it directly into the tumor? And can we give it safely through an IV? So in 2017, we published our phase 1 study of intratumoral injection of HSV1716 into kids with cancer. This is my mentor, Dr. Kripe, holding up the virus as they're getting ready to hand it off to the interventional radiologist to inject it into the tumor. So again, we were looking at safety in kids and young adults with solid tumors. We first looked at giving it directly into the tumor by using CT guidance. So we would have our interventional radiologist place a needle directly into the tumor, and then we would hand them the virus and they'd squirt it right into the tumor. Then we also looked at giving it just through an IV, mixed it up in a bag and hung it just like a bag of saline. We measured the immune response when we were looking at this study. We looked at how much virus was in the bloodstream after treatment. We also wanted to make sure that this virus wasn't going to be shed, right? That if a kid goes home, they're not going to be spitting or peeing and they're going to have a virus shed everywhere. So we wanted to make sure that that aspect was safe as well. And we looked at again, just that quick peek to see if there was any signs of response. So this was our study design. We had 3 dose levels. It's a 3+3 design, as you guys have heard earlier. And we gave 3 dose levels of intratumoral and 2 dose levels, actually, of the IV injection. We had 18 total patients on these 2 studies. So 9 patients got the virus directly into the tumor, 9 patients got it through the IV. And patients were eligible for additional injections if a response was seen after their first injection. And we did have 2 patients that were able to get a second injection. So we measured the tumor by CT, MRIs, and PET. We found no dose-limiting toxicities. We saw no viral shedding, meaning if we looked at their urine, their saliva, things like that, there was no virus there. We saw minimal adverse effects, so just a little bit of low-grade fever, some chills, maybe some mild anemia, a little bit of drop in counts, but nothing compared to the chemotherapy these kids see earlier. 6 of the 8 patients who did not have antibodies to HSV eventually, by a month after getting their HSV virus, had antibodies to HSV. So that tells us that their immune system learned, this oncolytic virus thing isn't supposed to be here. And if it learned that, there's potential that it could also learn to find things on the tumor surface. We couldn't prove that, unfortunately, but we did see that it did recognize the virus was not supposed to be there, and they built antibodies to at least the virus. 6 of the 9 patients had HSV detectable genomes in their blood on day 4. So on the first day when you inject it, that means that yes, the virus got in, it's there, no big deal. But on day 4, if you still see virus in the blood, that means that it's actually getting in and making copies of itself. So that was real exciting to see. This is just a table showing you all of the patients who got the intratumoral dosing and which types of cancer they had. So rhabdomyosarcomas, a clival chordoma, renal cell carcinoma, and these patients ranged anywhere from 8 up to, I believe, 30 years in age. And we injected, one was in the skull base, one was a lung met, one was a paraspinal mass, a couple were big masses in the belly. And here you can see one of our 16-year-old patients who got, you can see the 2 needles up here going right into the tumor. And we gave a dose of virus, we split the virus dose and gave a dose into each of those 2 different spots. And then this is a PET scan on a different patient who also got intratumoral injection. So here is where we injected the virus on the first day. And here you can see about 2 weeks later, there's very minimal uptake here. So then we gave a second dose about a month later, and you can see that, ooh, it's really active. But then after the second dose, this SUV started to go down by about a month after the second dose. And then here about 2 months after the second dose, it was still pretty minimal. So that was exciting to see. We saw a little flare, meaning it did get in and it caused some immune response, and then it calmed back down. This is again showing the same thing in a different patient. Here's, whoops, the needles going into the tumor, and it had what's called an SUV. When we're talking about PET scans, SUV is how bright or how active it is. It had an SUV of 3.2, and then 2 weeks later, it went up to 10.1, and we saw a pleural effusion. And at first we were like, oh gosh, is this kid's tumor progressing? But then 2 weeks after that 2-week time point, it went back down to an SUV of only 4, and that pleural effusion was getting better. So that tells us this was just the immune system responding to the virus, which is a good thing. that's called pseudoprogression. It's something that we sometimes see in oncolytic virotherapy. Interestingly, the tumor that we didn't inject, so we injected this guy up here, but the tumor over here that we didn't inject also similarly had a little bit of SUV uptake here, got really bright even though we didn't inject it, got really bright right here, and then calmed back down again. So then we said, all right, we showed that it was safe by giving it directly into the tumor. What if we give it IV? So again, this is just kind of a timeline showing you how it worked. It's a 3+3 design, 2 different dose levels. Patients were screened, they came into clinic, they got their first dose. We kept them overnight in the hospital just to watch, because this was the first time we were ever doing a herpes simplex virus through an IV. And we got their labs on day 4, 7, and then day 14 and 28, we got labs and scans. So what happened, like I said, we admitted them overnight for close observation, a little bit of fevers, chills, headache, fatigue. We did keep them on contact isolation just because we weren't sure of the shedding results at that time point. And then they came in for a clinic visit and then weekly for the first month. We had all the families do really good hand washing and hygiene again because we weren't sure about that viral shedding question. And like I said, we did the follow-up imaging. This is a table of all the kiddos who got the intravenous dose of virus. And as you can see, the one I highlighted here was a 16-year-old guy with multiply relapsed neuroblastoma. And he got our highest dose of the intravenous virus given here. And this is just another nice little table showing you a little easier to read the different patients and their age ranges. Again, in the intravenous arm, our youngest patient was 11, and we went up to age 30. Again, we kind of saw that same transient increase in the PET avidity, meaning we saw that at the time we started, whoops, gotta get used to this pointer. At the time we started, the SUV was at about 7. When we looked again 2 weeks later, it was at about 8. And then when we looked again at day 42, it was down to 6.2. We had added pazopanib to this case. We actually wrote an IND or a special case to this patient because her tumor showed some evidence that it could respond well to pazopanib. So we asked the FDA and they said, sure, you can give both at the same time. Unfortunately, she ultimately, the therapy did not work and she died of her disease, but we did see some initial responses. So in summary, we learned that both intravenous and intratumoral HSV was safe in kids and young adults. There were no big significant side effects. We did see stable disease in 2 of the 9 patients on the intravenous arm. We saw evidence that the virus was getting in and making copies of itself. We saw that 5 of the patients who were negative became positive in terms of developing antibodies by day 28, which suggests that the virus was replicating and the immune system was doing its job. We did see the transient increases in PET avidity, and we think that the ability to see the virus in the blood may have been a little dependent on how much tumor there was, because if you had a really big tumor, trying to see some of that virus get out into the bloodstream if it wasn't super vascular, maybe that could have played a role in why we didn't see that in all patients. And then the histology too, like I said, if it's more vascular or if it's more differentiated, like some of our neuroblastomas can be, you may not see as much virus being replicated and put out into the blood. So we talked about how it's safe. These patients all had rapidly progressive cancers, which is the majority of patients who go on a phase 1 study. The TVEC study, interestingly enough, showed that it takes 4 months on average to develop an anti-tumor immunity. And so none of our patients actually lived to that 4-month time point. So it's one of those things where maybe if we had given it in conjunction with something else, we could have seen more responses. But which is why my next point is virus alone is unlikely to be successful, just like most of our therapies. Kids and young adults may be best suited for IV therapy, as most kids actually don't have antibodies to HSV. And next, I wanted to briefly talk about, to end on a little bit more of a high note, a different type of oncolytic HSV done by my colleague Greg Friedman at the University of Alabama. This oncolytic herpes simplex virus was given directly into brain tumors, and this was published in the New England Journal of Medicine. To get published in the New England Journal of Medicine, you gotta have something good. So this is a G207 virus, and this again lacks the genes for normal replication in brain tissue. This was a phase 1 trial given into brain tumors. They put 1 to 4 catheters directly into these kids' tumors in their brain. They went to the OR, the neurosurgeon placed these catheters, and they injected the virus directly into the tumor via a slow infusion over about 6 hours. The last 2 cohorts of this study also got 5 gray of radiation to the area of the tumor that was getting the virus injected. There were 12 patients on this study, aged 7 to 18. There were no dose-limiting toxicities, no significant adverse events. There was no virus shedding seen, and a median overall survival of 12.2 months. 4 of the 11 patients were alive 18 months after the treatment, which for high-grade gliomas is really, really good. Then the other really cool thing is that they saw on imaging, in pathology, and clinically responses in 11 of the 12 patients. So hope that we're getting there with oncolytic virotherapy. They also saw a markedly increased number of tumor-infiltrating lymphocytes. So this is looking at different patients. This is 1 patient, 2 patient, 3 patient, 4 patient. This is their tumor before their treatment. This is their tumor after treatment, just at different impacts or magnifications under the microscope. So this is low, medium, and high. And these are all about 3 to 9 months after they were injected. And you can see this, the brown dots are the tumor-infiltrating lymphocytes. So all of these patients had their immune system activated and recruited into their tumor well after, and even months after they had gotten their treatment. So what do we do with all this? So 1, do we increase the doses of the virus, the frequency and the number of doses? When we first started, we kind of just started with 1. We haven't seen a lot of toxicity, so that tells us we can always give more. Again, like most cancer therapies, monotherapy is probably not likely to be the thing that gets us to where we want to be. So we need rational combination treatments to keep the tumor growth at bay while that immune response develops. We're hoping to combine both intratumoral and intravenous virus. So if you've got a big tumor somewhere that needs injected, because we've seen responses, what we call abscopal effect, meaning you inject one tumor and another tumor shrinks and goes away. But we also know that there's also little teeny small distant metastatic things that we may not see, so giving it IV as well. And the intratumoral one helps to debulk and boost that immunogenic cell death. We would also like to concentrate the IV doses first before the body develops a robust immune response, because if you give the IV virus after they've already developed their immune response, there's a chance that their immune system could attack the virus before it even gets to the tumor. So we have to be real smart in how we design these studies. Big things, we need to understand the tumor microenvironment much better, developing the preclinical models, so looking at mice and things like that in the lab and comparing that to humans when you're looking at the immune system is really complicated. So we need to figure out a way to get around that and make this make more sense before we can continue to test it in kids. We definitely want to increase our utilization of our very precious patient samples that we get from kids on other studies. So just that when you guys sign up for biology studies and you donate your tumor samples or your blood samples, using those in the lab to help us learn as much as we can to keep this field moving forward. So potential combinations, can we combine it with chemotherapy? Can we combine it with radiation therapy as they did in that brain tumor study with the G207 virus? Can we combine it with checkpoint inhibitors? Can we combine it with cytokines? So overall, oncolytic viruses are an exciting new type of cancer therapy. We expect fewer short and long-term side effects from this than the current standard therapies that we use. Oncolytic viruses are looking promising for neuroblastoma, and HSV is a very common virus that causes cold sores. The other cool thing about, like nerd out cool thing about using oncolytic herpes viruses is that thymidine kinase is the gene that acyclovir responds to. So if this oncolytic virus ever went haywire, we could give acyclovir and it would stop right away. So we've got a nice control mechanism for it too. The oncolytic herpes simplex viruses have been well tolerated so far and are just starting to show us that they're going to start working. And newer types of virus are being developed in the lab. I'm continuously talking with a bunch of lab companies about, okay, you're doing this with neuroblastoma, but have you looked at this? Have you done this? Like Meg said, it's a lot of collaboration. And right now, that's where it is. It's in the labs. Everybody's trying to be really smart because we haven't seen the responses that we're hoping to yet. We need to go back and figure out before we, like you very appropriately said, you don't want your kid to be an experiment. We hear that, we don't either, so we're going back to make it better before we bring it to the next clinical trial. And I want to thank our patients and families who have participated in the trial, Pat and the CNCF committee, and our clinical research office at Nationwide Children's. This is a view of our magic forest at Nationwide Children's, and Dr. Kripe and his lab. And I'll take any questions.
Thank you, Dr. Streby.
Hi.
Hello.
Back.
Awesome.
I got a lot of notes for you, honey.
Uh-oh. Bring it on. I'm ready.
First of all, I like to start by saying I am not, against trials.
Oh, no.
No. I'm just saying, I do surveys, I do studies. It's all how it's presented to me. I am the first one to pull out a pen or paper, whether it's good, bad. I like to give my feedback. So I'm not totally against it and I'm not bashing it or whatever. It's just how it's presented to me. And if, I'm gonna be honest, if you come to me and present it to me and say, hey, guess what we do? It's so cool. We inject your child with the herpes virus. I'm gonna be looking at you like, lady, are you crazy?
Uh-huh.
How is that cool?
Yep.
That word cool is not cool, because that's gonna say, wait a minute, I don't know about that. So it's all in how it's presented to me. And I did not hear anything in your presentation about how long do the rats have the neuroblastoma virus before you start to treat it, because apparently we don't know how long our kids have been sick and how it has progressed, or do you give after a couple days start treating this one, or do you study this mice for a month, or how long do you look at this in a petri dish before you start working on the mice? All of that stuff to me comes into play because we're desperate at this point. We have tried all of the stuff that you guys say works, but it didn't work with our kid. And so now we're trying to do everything to save our kid. So those things, to me, play a factor. And also raise, height, size. I didn't see any of that in your data either. Of course, that's different from every kid. No kids are the same. And sometimes the disease acts different within Caucasian child, Asian child, Black child. It's all different. None of that was in your data of how it worked with a particular child or how long they had this disease and stuff like that. To me, it's not finished.
Nope, it's not.
And I'm not trying to be, mean or anything, because it's just like all of the facts are not there. And if I was presented it like that, I'd have been like,
Well, that's
next.
why I mentioned that there are no open trials right now for it, because
Right.
I totally agree with you. We are not anywhere near ready for it yet. And when you asked about, thank you first of all for all your questions. They were all fabulous. When you first asked about when we inject or when we start to treat the mice, that's one of the big limitations of studying things in mice compared to in kids,
Right.
because we can't put the mice through all the treatments exactly the same way that the kids go through the treatments and then see, okay, did they relapse, and then treat it in that relapse setting. We have to start just when we see the tumor start to grow in the mice and go from there.
So it's new to the disease is new. You guys have not studied how long the mice can actually live with the neuroblastoma inside of it.
We know in general mice actually only live about 30 days without,
Right.
they don't live very long with the tumor. So
Right.
to study treatments, we have to start them kind of quick.
Right, so that's just with the tumor, they only live 30 days. See, that's not in there as well. That's something I would like to know, like this tumor is taking this mice out really quick.
Yeah.
But the sample of tumor that you're given is, you don't know how old that tumor is. It's just coming from a random kid that got sick, right?
So most of them are kids that either relapsed or at diagnosis, yeah.
Right, and again, that was something that I would like to know as a parent. How long did this kid have it? Was it first, second relapse, and things like that? That's my deciding factor of how I go to the next phase in this situation. Do I just take my kid home, or do I trust you on what you're saying?
Right. I'll move this down here. Apologize, having a little bit of a vagal response. Early morning flight. The other piece that I wanted to mention, let me move this down here, was your comment about I got it. Yeah, I think you guys can hear me, right? Was your question about the patient's like race and how long it had been from the time of their treatment? We have all of that in the paper. It's just for the purposes of this meeting today, I didn't want to include all of the details, but it's all there in the paper, because I completely agree with you. It's very important.
Anyone else? Go ahead.
Hi, Dr. Streby. You probably can't see me. Hi. Thank you so much for your presentation. That's really interesting and exciting, I guess, that there's a new type of therapy that might be able to target cancer, neuroblastoma specifically. I saw that your study had different childhood cancers. Were there any cancers? I guess I have a couple of questions. The one is, were there any cancers that responded well or particularly well to your to the oncolytic viral treatment? And then secondly, which other viruses are you looking at that might even more specifically target neuroblastoma or neural cells?
So to your first question, sorry, what was your first question again?
Are there any of the other pediatric cancers in your trial that responded particularly well?
So unfortunately, in our whole trial, we didn't see a whole lot of responses. All we saw was stable disease, which to us is not enough of a response. So no, we did not see in any of the pediatric cancers any great responses in that trial. But like we said, in the brain tumor study, we saw some really nice responses, but not in the one that we did. And then your second question.
Which other viruses are you looking at that might target neuroblastoma?
So the company that I had mentioned, I believe, is working with the vaccinia virus, but we're also working still with oncolytic herpes simplex virus, but vaccinia virus is another big one.
Okay, sorry, I know one more question.
Yeah.
Did you look at, prior to treating the children, whether or not they had existing antibodies to the herpes simplex virus, and did that affect the outcome?
So we did look to see if, and that's why when we said that they were seronegative, it meant that they had not had antibodies to the herpes simplex virus, but some patients did. But the numbers of patients that we saw were too small to be able to tell if those antibodies being there made a difference in terms of how well it worked.
Okay, thank you.
Yeah.
Any other questions? Okay, one more.
Thank you, Dr. Streby. It's promising to know that we can potentially use viruses for a good thing, kind of like that movie World War Z with Brad Pitt, where he used it to disguise himself from the zombies.
Right.
Yeah, or I Am Legend.
Yep.
But I digress. Question on how you go about selecting which virus for which type of cancer. And when I saw that this was on the agenda, I did a little bit of research just kind of on the history of using this therapy. Were there any cases of transmission to family members? I know that's a concern with these viruses for any of these trials.
So that's what when I was talking about shedding, we saw absolutely no evidence of virus shedding. We asked family members specifically, we gave them a survey to report if they had any sort of cold sores or headaches or any symptoms for anyone in their household, and no one did. So that was a very reassuring thing. And then how do we pick the type of cancer or the type of virus that we use? It's honestly a lot of what Meg was talking about. We're stuck by what industries want. There was one company I was working with that they were going to totally close down all pediatric cancer studies for virotherapy. And then one of the employees' kids ended up being diagnosed with a Wilms tumor. And they were like, oh, maybe we do need to look at this. So unfortunately, even with all the carrots and sticks that are out there, we still need to do a lot of work in convincing the drug companies to look at the pediatric cancers. But excuse me, we just look to see which one works best. I apologize, I had a very early morning flight today. We look to see which one works best in the preclinical models and try to study it as best we can and then move it forward.
All right, anyone else? Okay, thank you, Dr. Streby.
Yep, thank you.
We're going to go ahead and take a 15-minute break. There's some munchy things there and soft drinks and everything, so about 15 minutes.